This presentation will be on radiation doses in radiology, exploring the current status, concerns, and prospects. Radiation plays an extremely important role in both past and present processes in diagnosing patients. Technologies that utilize radiation for diagnostic purposes include CT scans, X-rays, nuclear medicine, and PET scans. The use of radioactive markers is extremely useful in providing doctors with information on organ functioning, particularly in thyroid, heart, liver, and spleen. Radiotherapy is also used in treatments, especially in the treatment of diseases like cancer, as well as the sterilization of medical equipment. Radiation dosage varies between each technology, but each dosage of radiation, whether high or low, does carry some risks. The first uses of radiation in medicine were extremely unsafe and often rendered deadly effects to those who were exposed to such treatment. Through advancements in technology, the risk of exposure to great doses of radiation through the diagnostic process has decreased.
Currently, in radiology, imaging is moving away from using ionizing radiation, that is defined by the World Health Organization as radiation that increases the risk of developing cancer. This is reflected as non-ionizing ultrasounds have led the way in imaging referrals in Australia. Closely behind ultrasound are X-rays, which utilize ionizing radiation, albeit X-rays do not elicit high doses of radiation, with the Australian Radiation Protection and Nuclear Safety Agency, or APANSA, describing a negligible risk of cancer development in X-rays of extremities, with an equivalent of 6 hours of background radiation. All other imaging modalities, which have a higher exposure, make up less than 20% of imaging referrals in Australia. Occupational exposure of low-dose ionizing radiation is an issue. However, measures are put in place for this. An average of 20 millisieverts over 5 years is the maximum allowable limits for healthcare workers. As per APANSA, logging of exposures and protective equipment is required for staff involved. Studies indicate that original investigations on the deleterious effects of imaging radiation are incorrect and that doses of less than 100 to 200 millisieverts is not harmful at all. Medical imaging is greatly beneficial for patients and is invaluable in the diagnosis of disease like tumours and even confirming child abuse. Also, it is not limited to the diagnosis of disease, as it has been seen in therapeutics, as high-intensity focused ultrasound have been used widely in the removal of solid tumours and uterine fibroids in a surgical setting.
Radiation from medical imaging procedure can be harmful to both patient and medical staff. The probability of cancer in patients who had multiple CT scans is expected to be 2.7 to 12% in a lifetime. The table here illustrates the overall cancer risk per CTA procedure. The probability is calculated based on the mean effective dose and risk coefficient. As can be seen, for CTA, the overall cancer risk is 13 to 49 per 10 to the power 5 procedure, and the highest probability of cancer is with pelvis, abdomen, and chest CTA. For the cancer risk estimation, patient age and gender should be considered because young patients have more remaining years during which radiation-induced cancer might develop, and female are 1.6 times more radiosensitive than male. Medical staff are equally affected by radiation as they perform the procedure for a number of years. Some of the biological effects caused by radiation are cataracts, skin burn, and hair loss. Also, the continuous low dose of radiation exposure for a long time can cause significant DNA damage in healthcare professionals. Due to potential risks of radiation, management of patient and staff radiation dose is a topic of concern. Patient radiation dose can be reduced by dose recording using advanced technology for imaging procedure and implementing ALARA principle. Similarly, staff dose management can be achieved by using a radiation dose limit, real-time personal dose monitoring, and providing education and training about radiation protection to the medical staff.
My mates already told there are some risks associated with the use of X-rays, such as damages in the DNA, increasing the possibility of developing cancer, tissue effects such as cataract, skin redding, and hair loss. For balancing benefits and risk, various patient factors have to be taken into account. Although the benefits outweigh the risk, nowadays lines of research look for ways in which radiation dose is reduced or avoided. An example of avoiding X-rays is the following, in which Argentine scientists from the CIC create optical mammography that does not compress the breast or use X-rays. In this way, this method can be used with more frequency and in young women, which, as I said before, one of the highest risk group is that of young people. The objective is not substituting traditional mammography but improving it, solving problems such as continuous monitoring of young females that traditional mammography cannot solve. The following example is a clear one of how scientists also try to reduce radiation dose by using protons instead of photons in this case. Proton therapy is a radiotherapy treatment that uses a beam of protons to irradiate just the desirable tissue, instead of photons, which are used to irradiate the whole tissue in traditional radiotherapy. Proton beams are produced using hydrogen atoms by extracting the only electron they have and a cyclotron. Radiation of the desirable tissue is achieved thanks to focusing. In proton therapy, it is possible as protons have a relatively higher mass than other subatomic particles.
As has been previously said, the benefits of radiation do greatly outweigh the risks. It's extremely useful in diagnosing many diseases and conditions that otherwise would be very hard to diagnose. Advancements in technology is helping to further increase the safety of radiation in medicine to patients and staff.